responsiveness. This is actually the main thing that I work on in my laboratory. We've been continuously funded for about 20 some years on this this area in asthma. And so we're really going to try to understand how the features of inflammation relate to what we call endogenous hyperresponsiveness, also called indirect hyperresponsiveness. These are the endogenous triggers for asthma. We're going to learn how this relates to the precise location of innate immune cells in the airway wall from studies that we've done. And then going back to the more common thing that people study, which is the endotype of asthma, we're going to look at how this relates to features of type 2 and non-type 2 inflammation, and really understand how the airway epithelium plays a unique role in this regard. So just so that we're all on the same page here, I realize from being the medical director of our pulmonary diagnostics lab that this is something that's very commonly misunderstood, how these tests are used. So just so that we're all on the same page, airway hyperresponsiveness is the increased sensitivity and exaggerated response to a trigger that causes airway narrowing. So this is an example of what's called a direct stimulus for airway hyperresponsiveness. So if you give someone with asthma something that directly constricts the airways, like methacholine, they typically have an exaggerated response, as is shown here. So their lung function is dropping down, and then when you cross 20%, that's where that's what we report out, what's called the PD20, the dose that causes a 20% drop. And so if you take a normal person and you just keep going out here, they will drop 20% as well. So the fact that they drop 20% doesn't mean that they have asthma. It's the dose at which they drop. And then the other thing is that when you use a direct stimulus like this, is very sensitive to airway geometry. So actually most people with COPD, for example, will have a positive methacholine challenge if they have reduced baseline lung function because of that. And there's many other factors. So it's not specific for asthma. It's just a test that shows that you have airway narrowing. And so if you're trying to make a distinction, this person has asthma, this person has COPD, this is not a great test for that, a direct test. Just so that we're all on board. And then, interestingly enough, there's a modest number of people with asthma that will have a negative direct test, and I'll go over that a little bit more. So the reason that this is so important is that this is really the key physiological abnormality in asthma. So, if you screen children that have airway hyperresponsiveness, they're more likely to develop other features of asthma. Those people who have relatively normal lung function, this is actually what's driving their symptoms, this propensity for their airways to vary in tone. It's associated with a decline in lung function, which doesn't occur in most people with asthma, and it's associated with the severity of exacerbations and escalating treatment. And this is particularly true when we talk about what's called indirect hyperresponsiveness. So just to kind of hammer home what I've been saying, so we have these direct stimuli, things like in the United States, it's pretty much all methacholine, but other things like histamine have been used in the past. That directly stimulates the airway smooth muscle, but also it causes secretion and nerve activation. Actually, probably the main reason that you get bronchoconstriction is actually a neural reflex through your airway nerves, which then activates the airway smooth muscle. But either way, it's directly causing airflow obstruction. Indirect stimuli, there's no bronchoconstrictor that's administered, any of those stimuli. And this includes things like dry air exercise and mannitol, things that shift the airway osmolarity, as well as allergen challenge. But you have to be allergically sensitized for that to play out. So you're not giving a bronchoconstrictor. So what's happening is that the cells of the airways are releasing components that then cause you to have bronchoconstriction. And here in this indirect or endogenous hyperresponsiveness is not very susceptible to that baseline lung function. And that's generally thought that you're releasing much more powerful bronchoconstrictors. So oftentimes people can start with normal lung function and then drop down with these very powerful bronchoconstrictors. So our examples are methacholine predominantly for direct, but indirect has the dry air exercise challenge, not a cardiopulmonary exercise test that has a different, I probably won't go into the details of that too much, but it's different. Then there's a similar way to do this without exercise called EVH, eukapnic voluntary hyperpnea. And so there you just have a 5% CO2 bath that they're breathing against so that you're allowed to breathe at this high level for 6 minutes. Hypertonic and hypotonic aerosols are well described. Cold air, it has a very minimal effect. Increases what's called your minute ventilation, but independent of exercise, not too much. And you probably realize from being in the clinic that this one, hypertonic aerosols with the mannitol challenge test, is now FDA approved as an indirect challenge test.
Just comment for those taking their boards, they want you to understand this distinction that Teal is hammering home. These are our board questions in allergy.
Oh, good. Well, that's always a vexing thing to me because we rewrote the standards and we broke it down into direct and indirect tests a number of years ago. We had the task force from the ERJ and the ATS that wrote that. But remarkably, there's not actually a guideline on how you use these tests. And I think that would be quite a helpful thing, but it keeps getting the best score at the program committee, but then never gets actually programmed by the ATS leadership. So someday, I guess we'll have to change that. I think it would be helpful. But so this slide is like, the key features of asthma are airway hyperresponsiveness, variable airflow obstruction, which leads to symptoms. And this is related to inflammation. So this is the definition that people use of asthma. And really what has kind of happened is that over time, the type of inflammation, or what we would say is the endotype of inflammation, has really become the driver of a lot of research into the pathogenesis of asthma and how you decide about treatments and so forth. But that's partly because it's more convenient to look here, especially in the periphery. But this is directly looking at airway dysfunction in asthma, and that's what we've been focusing on. And so our initial studies were really kind of what makes you have airway hyperresponsiveness, and then we've been really trying to relate this back to the endotype of asthma. And then, a key issue is not all inflammation is corticosteroid responsive, and of course, there's different approaches now. And so this is Ryan drew this up, but this is just to give you kind of an overview of the endotypes, which is really something that's very well developed in asthma, that many people, probably most people, have some element of T2 inflammation. And that initially was thought to be all related to type 2 effector T cells, and then more so related to ILC2s. Eosinophils are considered kind of a marker of this, but other studies suggest that they're actually involved in the regulation of inflammation, including through their PD-L1 on the cell surface. And then mast cells from our lab and from several others are really thought to be regulators of type 2 inflammation. But an interesting thing is, of course, a lot of people think of mast cells as a non-T2 cell. In fact, that's what the PRECISE network was studying, mast cell inhibitors for non-T2 inflammation. So if you have, once you're outside of the T2 realm, there's a bunch of different choices, and this includes kind of T1 inflammation. That's classically interferon-derived inflammation is the best way to think about that, and that's really thought to be related to cytotoxic T cells, macrophages, and ILC1s. But then you also have this whole other area of T3 inflammation. The good simplified way of thinking about that is it's related to inflammasome activation, downstream IL-1 beta, IL-18, Th17 cells. And then there's this whole idea that you maybe can have airway dysfunction in the absence of a lot of inflammation, and maybe that's neurally mediated or related directly to the airway smooth muscle. All right, pretty simple, huh? But that's what I think about as a researcher and trying to bring this together, but really trying to understand how it relates to airway dysfunction, because I think one of the limitations to a lot of studies is that you can, in fact, in our studies, we find people that have very strong type 2 markers and have no airway dysfunction whatsoever. And so making that connection is really important. So this is just where I started was really looking at that dry air exercise challenge test. And more generally, it's really just a measure of indirect hyperresponsiveness. It doesn't get used a lot because it's considered a maximal challenge test. So unlike the methacholine challenge or the mannitol challenge, where you're doing it incrementally, here you basically have to take someone up to 6 minutes of high ventilation. It's the maximal stimulus. So some people will drop their lung function by like 70%. And so you have to be, there's much more in the way of safety criteria for doing this type of test. People have, in fact, sometimes kind of life-threatening bronchoconstriction.
Teal, having said that, why would you put somebody through that if you have other challenges you could do?
Well, when we started, we really didn't have, people had the hypertonic saline test that was well described in Europe, would be an incremental test. It's actually the last, you basically give incrementally larger amounts of hypertonic saline. And then it wasn't until they reformulated mannitol, which has limited solubility, so they formulated it as a dry powder, that they were able to use an incremental test like that. But it is, I have to say, like the dry air exercise challenge test is really only like hitting that 6 minutes of dry air at 85% of your heart rate, which is a surrogate for being at about 60% of your maximum ventilation. That only works out if you have a fit, person. I was going to say fit young person, but I think, actually fit whatever age, that'll work out if, and the reality is, you don't want them to have comorbidities and stuff like that when you're doing those kind of challenge tests. So, and so we have a higher lung function threshold for that's in the guidelines for the safety of doing dry air exercise challenge. You have to start at relatively normal lung function just for safety reasons. And in mannitol challenge, you can slide down a little bit lower and it's still considered safe. And this is just a call out that, when you're exercising, it's generally thought that the reason you bronchoconstrict is that high ventilation challenge causes you to lose water from the airway surface liquid here above the epithelium. And then you can create a similar thing by adding a hyperosmolar stimulus, either hypertonic saline or mannitol are the two challenge tests. And that since Len was the hypertonic saline challenge, actually the last dose of the hypertonic saline is 8 minutes of breathing hypertonic saline. So you go longer time, whereas like the mannitol challenge is having it's a dry powder capsule and you just have a higher dose each time. So, but this, like I say, this causes fairly significant dry air exercise, causes people to initially to bronchodilate a little bit and then bronchoconstrict. You have to have that 6 minutes of high ventilation for this to be a valid test. It often is not achieved unless you have someone who's fairly fit and so forth. These are hyperpolarized helium imaging showing things being pretty normal at baseline. The thing that a series of these hyperpolarized helium images showed that you actually get regional airway closure. So these people are actually losing portions of their lung. if they have severe bronchoconstriction, and which is also what's shown during other forms of exacerbation, in that the airways are not uniform. There's regional airway closure. So, you know, the things that we showed early on was really that you had features of both mast cell and eosinophil activation. When you did that stimulus, you get sustained leukotriene release. They actually have higher basal levels of leukotriene levels. That's associated with mucin release, along with the sensory nerve activation, neurokinins. And that led us to identify one target that we've been developing over time called secreted phospholipase A2 group 10, which seems to be a really likely target that we really haven't further developed it towards a therapy, but I think it's quite a likely target. So just to kind of go over these traits, this is from our JCI paper. When we phenotyped this large group of people, and then this is actually the third of these sets of studies that we did, where we phenotyped individuals for airway hyperresponsiveness, you can see, you know, so there's controls, there's individuals with asthma. You can see there's quite a lot of overlap if you plot it out this way, including a couple of the patients with asthma actually a bunch of the patients with asthma that would be considered to have an indeterminate test. That is, it takes enough methacholine to get them to bronchoconstrict that it neither gives you more likely or less likely that they have asthma. It's indeterminate in that what used to be in the kind of 4 to 8 milligrams per milliliter range when we were using concentrations, that's now converted over to a dose. And that indeterminate dose is, you know, above about 200 or so. But if you look at the patients with asthma versus the controls, what you can see is that there's a whole lot of patients with asthma up here that don't trigger with the dry air exercise challenge study, but then there's also many of the asthma patients can trigger with that particular stimulus, and there's quite a lot of variation. So it gives you a really nice phenotype, because you have these individuals with and without it, and it varies in severity, and it's distinct. And so the interesting thing is our first study, this is from 2010, from a while ago, we weren't actually looking for mast cells, even though we had shown mast cell degranulation and so forth, but we were looking at kind of the underpinnings of indirect hyperresponsiveness. So along with a lot of type 1 genes, and pretty much all the genes, all these genes in this list here have now been identified as clear targets in other studies, many in epithelial brushings. There are these 2 mast cell genes that showed up there. And this is just looking at the difference between the EIB negative, exercise-induced bronchoconstriction negative, and the positive people. So they have more of these mast cells and a lot of other asthma-related genes, like the trefoil factors and tetraspanins and anterior gradient and so forth. And so we initially looked in epithelial brushings for this. In a prior study by the UCSF group had looked at these genes related to type 2 inflammation in a much larger population, but they weren't phenotyped for airway dysfunction. So the interesting thing here is that you can see that there's really quite a close relationship between the precise copy number of tryptase and CPA3, these 2 mast cell genes, and a much weaker relationship for chymase. And the other thing that you can see is that chymase copy number is much, much lower. So these are mostly expressing just these 2 proteases, the CPA3 and tryptase, and not chymase. And this is interesting, probably only if you really understand this field about mast cells, because the mast cells that are supposed to be in the mucosa, and the mucosa actually involves the lamina propria, which is here, the lamina reticularis, and the epithelium, are only supposed to really be these tryptase-only mast cells, whereas the ones that have CPA3 and chymase are meant to be tissue mast cells. So the curious thing is that this sort of intermediate phenotype of mast cells in between a tissue type mast cell and a mucosal mast cell are showing up in the epithelial brushings. So this is actually an illustration of what took us a ton of time. We did essentially a three-dimensional reconstruction of the airways of these biopsies using something called stereology. And it shows a very, very surprising result that in the controls, which are over here, there's actually lots of mast cells. Matter of fact, more mast cells in the controls, but they're all in the subepithelial space there. If you take the person with asthma, you can see this airway smooth muscle, thickened lamina reticularis, goblet cells. That doesn't trigger to dry air, EIB negative. The mast cells are also predominantly in the subepithelial space, but these dramatically shift to the epithelium in in the group that has exercise-induced bronchoconstriction. So they both shift in their phenotype and in their location to the epithelium. This is just showing some of the data plotted out across the whole population, showing that this is now a ratio of the below epithelium to the above epithelium overall. So you can see it's altered in asthma, but there's a lot of variation. That variation is related to whether or not they have indirect hyperresponsiveness. And
Why did they have that?
well, I mean, we have the strongest, that's right. So most people, when they enroll people in studies, potentially wouldn't even have that data. Those all have a positive methylcholine challenge and an appropriate story. So they would be they would certainly have a diagnosis of asthma. The thing I guess we're showing here is that they don't have, they're not triggering with these active stimuli for. And you may or may not be able to identify that by talking with them, but they certainly have asthma. They clinically, yeah, exactly. So, which is, we all know that there's quite a bit of heterogeneity in the type of inflammation and so forth, and symptomatology and so forth. So the presumption is that someone in that category, like in the right setting, like a recent viral infection or a lot of allergen exposure, might then shift over into this other category. But that's not really been very well shown in the literature. And you can see how doing a study like this of taking someone and doing this level of airway, biopsies and so forth would be really difficult. But there is just to further digress, this finding was actually replicated not with quite the same quantitative morphometry, but by Celeste Postberg. She did mannitol challenge, and then she randomized them to inhaled steroid therapy, and the inhaled steroid therapy in those that it was effective, and not the whole population was the inhaled steroid therapy effective. They actually had a reduction in the mast cells and the epithelium, especially in the type 2 positive patients. So suggesting, again, it's a treatable target. So, is this really type 2 inflammation? I think that was kind of what we were targeting. So we looked at the type 2 gene expression, looking at the type 2 gene mean here. So this is airway type 2 gene expression, which is not perfectly correlated with peripheral markers like eosinophilia out in the periphery. And Mike Peters helped us with that. But, the interesting thing is that, so the people with EIB have a tendency to be a bit more type 2 high, but there's a lot of them that would be considered type 2 low by the type 2 gene mean that Mike Peters and others had described. So if you look at the ratio of mast cells and that shift in mast cells in relationship to the type 2 gene mean, it's pretty good. It actually looks like it needs to be transformed here, but the thing that really we thought is interesting is that this thing that we don't really understand, but CPA3 expression in mast cells is just extremely tightly associated with the T2 gene mean. So this kind of unusual finding that these mast cells are expressing more proteases in the epithelium than they would otherwise be expected to. It's also associated with this specific of being type 2.
Is there some crosstalk between T2 cells and why mast cells upregulate that enzyme?
Yeah, possibly. I mean, I think that's one thing that we haven't been able to fully figure out. We in our ERJ paper, I think I'm going to show you that in a sec here. We showed that how you could silence kinase, but we really haven't been able to figure out the regulation of CPA3 so far. But yeah, that would be a good thought, that it's turned on in mast cells by something, or that's the thing, right? So I think you would think that what this means is that there's migration of tissue mast cells to the epithelium and then they lose kinase. At least that's the way I was like, I think about it. The way you're thinking about it is exactly what Josh Boyce told me, like, oh, these are tryptase positive cells and something else has turned on CPA3. But so far there's not strong evidence from their lab either that there's something specific. They have a number of studies, using like TGF beta and so forth that do replicate some of these findings when they do it in culture systems. But anyway, the thing I would say about mast cells again is whether or not they're T2 high or T2 low. Like I say, there's ongoing work with mast cell inhibition for non-T2 asthma. I don't think they've completed that yet. Someone maybe can correct me if I'm wrong about that. But either way, certainly mast cells under the influence of IL-33, like an epithelial cytokine, make a lot of type 2 cytokines. We've also kind of been interested in this one, that TSLP, like that more TSLP. It's hard to show more IL-33 from the epithelium directly in primary human studies, but in primary human studies, like this one from one of our prior papers, showed that if you just did a scratch wound, you got lots of TSLP from the asthmatic epithelial cells. This is ex vivo culture of epithelial cells in that panel, and then what we showed. We were trying to look at, whether or not you could get more IL-33, because this seems like this is IL-33 mediated in response to a challenge. And that turns out to be quite a challenging thing, because IL-33 is so proteolytically activated and inactivated. It's hard to detect by an ELISA. So we used a ST2 reporter and basically shifted the airway osmolarity in mouse tissue segments. And so the interesting thing is that if they were allergically sensitized, they had more IL-33, as shown here. And then if you did a osmotic challenge, sorbitol, then you got about a doubling of the IL-33 activity. So it suggests that there's more IL-33 in response to kind of osmotic triggers. And whether or not that's something that really occurs acutely or not, I don't know that we really know. So I'm going to go into some modeling of this that we've generated. Does anyone have any questions that we want to?
I have a simple question from back when we were talking about mechanism and essentially events upregulated. Haven't we seen more therapeutic benefit from leukotriene biology? Quite a segue from where you are, but
that's a good one. Yeah, exactly. So I mean, we really just have a couple of approaches to block leukotrienes, right? Through 5-LO, and then of course they dropped the FLAP inhibitor, which again just would really inhibit 5-LO upstream of the leukotrienes and LTB4, and then the cis-LT1 receptor antagonists. Those are actually fairly effective for exercise-induced bronchoconstriction in many people, but not in all people. And so, but the presumption is that there's a whole series of downstream receptors, right? The receptor for LTE4, which is the leukotrienes get metabolized subsequently. So you have this whole series of receptors, and they have, in some cases, maybe protective effects. In some cases, maybe they cause bronchoconstriction. Studies really recently show that LTE4, which is past the cis-LT1 receptor, causes bronchoconstriction. And prior studies suggest that it causes, inflammation. So I think we just haven't fully realized that key target of, that was identified all those years ago with Frank Austin, showing that there's large quantities of cis-leukotrienes generated in the airways. So, and one of the reasons why the rate limiting step that feeds into this is phospholipase A2. It's the original release of arachidonate. And so the question is, what is regulating that rate limiting step? And which one is most relevant to asthma? And that's why I say that other thing, which I'm not really talking about, secreted PLA2 group 10, is really very clearly the one that's involved in asthma. It's about 2 to 3 times higher in asthma than in the controls in the airways. All right. Okay. My concern with secreted PLA2 is that, if you block that, it's so proximal that, you might have an innate immune defect as well. So it's whether or not it really can be targeted, I don't know. In humans, it can be targeted in mice. We knocked it out, and those mice are markedly protected from airway dysfunction in mice. All right, so we've a big part of our program is isolating airway epithelial cells, and really we were one of the first labs to get them from asthma and from control subjects with the idea that these are different. And then we developed this model system modeling what we see, in airway tissue biopsies, which is that there's mast cells in the epithelium. We didn't actually put them in the epithelium. We thought that was kind of a hard thing to do. So we put them, so epithelial cells growing here, mast cells in the basolateral compartment. And so the interesting thing is that the mast cells down here mediate this upregulation of IL-33 in the epithelium. And this, depending on which study, which cell type we use, can be very, very high. So this is with allergen and with and without IL-33 primed mast cells. And so, if you look at gene variants of IL-33, you might have a difference of like 1.5 IL-33 activity. So having mast cells there with the epithelium really markedly upregulates IL-33. This can be, this is after 48 hours. So this system, once you activate it, if you put an anti-IL-33 antibody in there, you can stop this. So suggesting that it's an active feed-forward loop. And then we have this very interesting result that 33 itself increases 33, whereas the type 2 cytokines are actually giving you a negative feedback loop here. So it can block the induction of IL-33. So, given their also role, and I would say to some degree controversy about whether or not airway eosinophilia is a specific marker that we should be looking at, we, using these same tissue samples, we looked at what the relationship between eosinophils and all of this is airway dysfunction. And the interesting thing here is that intra-epithelial eosinophils, as shown here, are really very specific for asthma. They only occurred in the individuals with asthma, and they're related to the severity of endogenous hyperresponsiveness. So it's not like what we saw before, that there's like a lot of submucosal eos in the control group per se, and that they shift. It's really just that they're in the epithelium only in that group. And the other thing that this really shows is that if you have type 2 biomarkers, you'll have eosinophils, but they're not necessarily in the epithelium. So there's this dissociation. So like some of the controls actually have eosinophils. They're just not in the epithelium there. So again, so that's the total number of intraepithelial eosinophils. You can see in general, it's like more with the EIB positive, but here there's a bit more spread. And then the subepithelial EOs, there's actually quite a lot of them in the control group, and then modest amount more in the asthma group, but not statistically significant. So really, it's so being type 2 means you have EOs. They're just not in the epithelium. If you have airway dysfunction, you then have EOs that are in the epithelium.
How does that correlate with blood eosinophils? Using that as a clinical marker for deciding the therapeutic?
Yeah, right. Not presume we didn't draw blood in this particular study, interestingly enough, which would have given the clearest answer on that. But presumably there's quite a bit of heterogeneity in blood eosinophils versus the and this is as a call out for the if you treat eosinophils with IL-33, you generate leukotrienes like we were talking about. If you then give IL-33 plus the leukotrienes to the mast cells, you essentially silence kinase, which is kind of phenoreplicating what we saw with that mast cell population. And I had just one slide from a study that we published. It's actually published. Sorry, that says in press, but this idea between T2 and non-T2, we did a study with sequencing that Ryan and Matt and Altman helped us with, and or really did. And they an interesting finding from that study is that there is what's interferon beta 1, a T1 signal that in mast cells is inducing type 2 signaling, so IL-13 generation. So, and this actually came from the primary analysis of the asthmatic and non-asthmatic airway epithelial cells. So really it's not as simple as you might have been thinking about there being, this sort of one group that's T2 and the other group that's non-T2, that there's actually probably most people have T2 and there's variations of non-T2 factors that are involved. So just to kind of summarize this, in the first paper on mast cells, there's this shift in mast cells. They go up here. They presumably have all their complement of proteases, but lose kinase up here, and they're involved in this feed-forward loop that regulates IL-13. And then in our second paper there's eosinophils. They're in the epithelium in association with hyperresponsiveness. They have the ability to phenocopy this mast cell phenotype. And if you're type 2, you have EOs. They're here in the submucosa. And interestingly enough, the submucosal EOs fairly directly correlate with the sputum EOs for reasons that we don't really understand. It must be that the EOs in the epithelium are like stuck there. So unfortunately, your sputum EOs are not a marker of airway dysfunction as much as the intraepithelial EOs. So the last thing we did was really
Graham, I agree with that. It's the world's advocate for sputum.
I think he reviewed that, so I don't know.
They got published.
Yes. Yeah. Interesting. We have that, both of us have a paper on actually, I guess I shouldn't say that. So we have a paper on airway periostin, which gives you a really pretty clear measure of tissue eosinophilia in the airways. Most of the work is really on peripheral periostin, so something that they're working on as well. So we sequenced the airway epithelium in that same group of individuals. And so you may have figured this out by now, but we didn't just see, you might expect us to see mast cell genes as shown there, Siglec-6, CPA3, tryptase, classical T2 genes like CLICA1, periostin, for example. But I think one of the key things is really that there's lots of non-T2 genes that are associated with this same phenotype of having airway dysfunction, particularly things like the IL-18 receptors. So IL-18 is in that T3 category. So we looked at, functional enrichment pathways, looking at leukocyte activation, cytokine production, immune response, and developed this pathway. And so the curious thing is that you can see that the ST2 receptor, IL-1, like 1, there is in the center node, which you might expect from what I've showed you so far. But the really clear things is that there's several other key important nodes for interferon gamma, so a T1 signal, and then IL-18 and its receptor, which is a T3 signal. So, we've been kind of modeling this. Again, in this case, now we're, rather than using phenotyped airway epithelial cells, we're using just normal airway epithelial cells that we get from transplant donors and activating the system with IL-33 to understand what's happening. So here, so this is basically after 48 hours. These are the mast cells. And this is with or without the airway epithelial cells here at the bottom. And what you can see, and with and without IL-33, but you can see that with doing nothing other than just sitting these things below the epithelium, you get IL-4 expression, which is somewhat amplified by IL-33, but not a lot. And the same thing for IL-5, just having that mast cell sitting there with the epithelium increases its IL-5 generation. So that brings up the possibility that actually those EOs that you see there are actually just downstream of mast cells because the mast cells are making the IL-5. But the other really curious thing is for IL-13, which, those sentinel studies by David Corey and Marcia Wilkes-Karp that were published at the same time, those are IL-13 mediates airway dysfunction. So for IL-13, you get a little bump when the cells are just cultured with airway epithelial cells, but for some reason, IL-33 has this very unique effect. And just to really highlight what this is showing, right? So if you treated those mast cells with IL-33 without the epithelium, it transiently induces a type 2 response, but then it goes back to its baseline as shown here. If you do that in the presence of the epithelium, then you've increased this many-fold, right? So there's epithelial dependence sustaining this response. And then the interesting thing is we then did maximum dose dexamethasone, and this is something we're kind of actively working on. Well, but you can see that the maximum dose of dexamethasone actually doesn't fully suppress this. It pretty significantly resistant to that. It reduces it, but not fully suppresses it. So those are in LAD2 cells, and these are in primary CD34 derived mast cells, again, showing this resistance to steroid suppression. So, I just is kind of trying to show that that not only do we have type 2 kind of pathways, those are associated with these intraepithelial eosinophils, which in turn are, of course, related to airway dysfunction, like the mast cells. But so are these other genes, IL-18 receptor, so a T3 pathway, and an interferon gamma T1 pathway. Just to kind of further blur the line here, and this is from our Blue Journal paper from this last year. IL-18, which again is like considered a T3 signal, this is actually inducing IL-13 in eosinophils. And as it turns out, there's several other labs that have been working on this. So there's actually a specific IL-18 induced population of eosinophils that have been identified. And then again, interferon gamma, just not surprising for IL-18, which is a regulator of interferon gamma. But IL-33 itself, a T2 signal, then is inducing interferon gamma in eosinophils. If you culture the eosinophils with the epithelium, you get an upregulation of IL-13 in the eosinophils. This has actually really been predominantly shown for those eosinophil progenitors. And then same thing with interferon gamma. Again, interferon gamma has been so controversial over time. People were actually trying to target it for a while, right? Giving interferon gamma to try to turn people away from being away from T2. Yeah. So, all right. So we're going to just end with our summary, which is that this shift of mast cells to the epithelium, it's associated with that endogenous airway hyperresponsiveness. It's really clearly the target. This is associated to some degree with T2 gene expression, but there's lots of people that don't have T2 gene expression, and we've been able to identify some of those specific genes. Eosinophils are associated with asthma and with endogenous hyperresponsiveness when they're in the EOs or in the epithelium. EOs in other locations are associated with being type 2. And then our sequencing shows that there's both T1 and T3 pathways in addition to T2 that are involved. And that's one of the things we're actively working on. All right, I just acknowledge my lab that's over here at the Center for Lung Biology, particularly the scientists, Ying and Hua there, along with Ryan and Matthew. And then Matt Altman has been helping us with the bioinformatics side of things, and Bill Altmaier with our mouse modeling in particular. And then as you might know, that we now have the Asthma and Allergic Disease Center. I'm the overall contact program director, but that's in collaboration with our friends over at Seattle Children's, as well as Ben Arroyo with Steve and Matt. So, all right, that's all I got for you guys.
Not easy stuff. You want to say that all again?
Yeah. I do actually also do clinical medicine, by the way. I just
how do you wear that hat when you go into clinic with all this knowledge? Does it help you therapeutically?
I think in general it helps therapeutically. I certainly have a good idea about why things are failing, it doesn't, there are people that don't always respond to therapy, but I think my background gives me reason to believe that changing therapy might help at times, so, and of course, most of even our biological therapy is still pretty type 2 targeted. So
the data you showed us about not fully dexamethasone suppressible.
Yeah.
Does that lead you to some therapeutic thoughts about clinically? We see that in patients as well. What that may say about their cell biology.
Yeah, the interesting the study that Celeste Postberg had in Jackie, gives the best insight. So they used what are called cryobiopsies, which to me is like completely novel. That's what we normally do for interstitial lung disease. It's a very large biopsy. So they didn't have three-dimensional data. They basically looked at mast cell staining. But in general, the people that responded best were people that had mast cells in the epithelium and were kind of type 2 predominant. They did peripheral phenotyping, which was, slightly different than what we did. If they were kind of non-T2, they measured the airway smooth muscle mast cell content based on the work of Chris Breitling and others before. And so if you were non-T2, in general, the mast cells had a tendency to be reduced in the airway smooth muscle, which I think raised a number of questions about how that all works. So, yeah.
I think there's neutrophilic asthma. I mean, that's a term I haven't heard in a long time. But there are the people that didn't respond to steroid and it had predominantly neutrophils in their biopsy.
Yeah, I mean, one thing I would say about neutrophil predominant, I mean, that is the classic sort of idea that you have these, T2 low patients that have neutrophils, and neutrophil activation is important. One thing is that in airway samples from a lot of these people that are highly T2, they have a lot of neutrophils there as well. So I think that idea that neutrophils are just remaining after you get rid of the more steroid responsive cells is a possibility. I think there's some evidence that they're pathogenic, and that's actually what Jason Dabley who has the other project in our U19 grant is really studying, like what the basis of non-T2, and they've set up a similar cell culture model looking at how Th17 cells and neutrophils interact with the epithelium. So I think that might be informative. But yeah, I don't know that we really know, particularly that neutrophils themselves are pathogenic, whether or not they're just residual.
And we have our people that we seem to randomly go from one biologic to another. Do you think sampling in your lab could actually help us predict who?
We don't have any certification of our lab for doing those things. Actually, I get frustrated with that. Like our clinical lab doesn't want to do induced sputum like EOs for us because they don't, for a number of reasons. So, but it's something that's of course easy for us to do in the lab, but we're not, certified to do that. So, in Canada, I don't know if Param really went over that with you. I mean, they basically convinced the government to support induced sputum eosinophils as a marker to help them make this distinction. So that's paid for by the Canadian government. So, so if anyone wants to get on board with me, but yeah, I think peripheral airway phenotyping is another key step that would be good. So
good. I saw there were 3 things in the chat. I don't know how you missed the word of the day. It was the very first slide. Airway, wasn't it?
Yeah, it was on the first slide there.
Chris answered the question. Anybody else, either in the chat or in the room?
Yeah,
thank you for
sure.
Very valuable presentation.
What was that?
See, like a year from now, what's advanced further.
Yeah, we did a review on biologics and how they affect airway hyperresponsiveness that we did with Chris Breitling and others. So it's pretty interesting. Not too many people in the biologics world use airway phenotyping like that. Mostly for safety. It's published. You can just look under my name. anti-TSLP has the best data. It actually affects both direct and indirect hyperresponsiveness. And then interestingly enough, Xolair is the other one that has the strongest data. Anti-eosinophil therapies, and I realize there's some industry people here, really have no effect on direct hyperresponsiveness, but then there's a kind of uncontrolled paper that would suggest it has an effect on indirect hyperresponsiveness. So something that probably needs further. But I would say, in this world of trying to predict what's going to be effective, looking actually directly at airway dysfunction is probably the thing that people should do rather than looking at endotypes, per se. So.
That makes good. I mean, that's the endpoint that you're looking for.
Right.
Is reversing bronchial hyperresponsiveness. That's
Yeah.
how you started the talk.
Yes, exactly. And it's a much, it increases your, it makes it much harder, but oftentimes you could use a smaller sample size if you use airway hyperresponsiveness as your target. So.
Right. Again,
All right.
any other remaining stories in the audience? Thanks again, Teal.